Good afternoon, everyone, and I would like to thank Dr. KDC Pathi and Dr. Malisi Bansal has given the opportunity to present my case here. And I would love to congratulate all the PLETSCON organizing committee for organizing such a wonderful conference. Before wasting much time, I would like to present some complex fracture lower end of the femur and variants of the HOPA fractures. I will start with the case. This is a 45-year young man sustained road traffic accident while driving motorcycle, slip and fell on the ground, has presented with a swelling, acute pain in the knee, inability to take weight. So this was a very simple fracture, looks as a simple, but this is a coronal plane fracture. So X-ray, AP view, lateral view, oblique view, CT scan, MRI was been mentioned in literature, and we are doing it. But I used to hold for the CT scan is a right choice to understand the fracture configurations, approaches, and the implant choice. We routinely miss these fractures in the 30% of the cases in our routine. If it is with the lower end of intraarticular fracture, if it is combined open fractures. So the open fractures has been very much described and classified here. Lutein Orbital, 1978. Here we need to know about the classification a little bit. Just I'll take a few minutes to describe this type 1, type 2, and type 3. Lutein has classified this type 1 on the Bloomstat line, but it's on the posterior cortex of the femur. And type 2, it is a intercalary and it is a combination on the coronal plane, and type 3, it is involving the whole of the condyle. So again, the classification was justified with the attachment of the lateral collateral ligaments and the oblique ligament and this lateral head of the gastrocnemius. If it is attached, so there is a stability. If it is not attached, it is unstable fractures. So the type 1 and the type 3 fracture is more look like it is easy to because there is a chunk is big. If it is a type 2, it is a combination, so it needs much more address in your approach, in your surgical demand. So the case was proceeded with the CT scan. This coronal fracture sometimes difficult to invert because it is too much posterior. So buttress plate and the headless 3.5 screw were used through the lateral parapatellar incision, and we have clamped it after reduction and the clamping was hold. We found this is a pre-op and this is after the 6 months of the surgery. I will proceed with the next stage and will end at the last with for the discussion. So this patient is having a full range of the motion and his back to work. This is the similar fracture having a sportsman sustained injury by fall from height. Only screw or with the plates. There was always a big debate on this case because someone will like to do the screw only and someone like to do the plate with combined with the screw. So we big assets in the making the template, size, position, direction, the surgical approach. Case was pre-planned before landing in OT, but this pattern is screw. So we did the intra-articular reductions, fixation, and buttressing to the lateral parapatellar incision in this case also. So we landed with the good fixation from the posterior side, then buttressing, and we put the AP screw. And this is after 12 months of the surgery. Again started, this is post-activity. Sometime of my cases of the HOPA fractures, I got a good result only by the screw, but once it is involving the intra-articular combination and the oblique angle is more towards the shaft, so there need to address with the buttress plate. So the plates are recommended in the osteoporosis combination. There is a high body mass index, and there's a poor compliance. So there's a lot of plates, neutralization plates, buttress plates, subchondral plate, and all this. This is bilateral Hoopa fractures. A young man, Riksha Puller, had a road traffic accident, presented with acute pain, swelling, and no neurovascular deficit. I proceeded with this case. So a lot of the things were in the mind will do for the bilateral plating approach, combined things. So it was a very difficult case. So I had planned with the TKR midline approach, reduction with the clamp, K-wire hold, and 3-point headless screw for the medial hoopa, anterior to posterior, and the plates and screw for the lateral fracture. So we did it. Para pictures is there. I need to hold all the pieces with the A-wires, screw followed by the bilateral plating. This is the unilateral plating. This was a post-operative 10th day, allowed the bending and this. After 5 months with the physiotherapy rehabilitation, is got a full range of the motion. This again is case number 4. The patient has high velocity trauma. There was a closed wound, no neurovascular deficit. We proceeded with the Schwarzbach approach. They were the first temporary hold by the K-wires, clamping followed by the few headless screw for the intraarticular combination, then lateral distal femoral locking plating and the medial plating. Sorry, apologies, lost in the para and the post-op fix, but this was after 6 months of the surgery. Patient is doing well, had a pain joint, pain-free joint, and routine job is doing. This case number 5, the patient had a high velocity trauma leading to the fracture on the knee without neurovascular deficit. 2-month-old fracture. It is very rigid. The young man has got a 2-month-old fracture, had a plaster for the 8 weeks, presented with a stiff knee and the slight mobility at the fracture site. It was just like a bamboo leg, but there was a mobility at the fracture site. So I gone for the CT scan, and planning was done to open the fracture site to explore the intraarticular fracture by midline incision. I did the tibial tuberosity osteotomy in this case because I need to expose all the fragment intraarticular. So we planned the TTO to explore the intraarticular pieces as knee was very much stiff. So we, after 2 months of the post-op, this is the X-ray. This is after the 6 months of the surgery, after the TTO. Patient is doing well. There is a full range of the knee motion and is pain-free, doing his routine activity. This is case number 6. The patient man has a young man had an injury on his left knee by fall from height, having the pain, swelling, inability to be awake. So in this case, just have planned to open it from the lateral incision and the medial incision. There were 2 separate incisions were given, lateral and the medial parapatellar, skin incision. All the small pieces were attached with suture with the ethibond, making the cleat hole to the major fragment tightened with the capsule. This is, and all the remaining intra-articular fragment were held by the K-wires, followed by the lateral and medial plating and 2.5 headless screw. This is lateral plating after the, and this is medial incision for the reconstruction plate. This is paroptic. This is after 2 months of the surgery, and this is after 4 months of the surgery. This is after 8 months of the surgery. Patient is doing well and resumed his daily activity work without pain, having full range of motion. So the take-home message was diagnosis of the such fracture was important. We miss in 30% of the HOPA fractures. Definitive pre-op planning is must. X-ray views, especially oblique views, important. CT scan makes your wow to wow in making the planning implant choice, size of the plates, surgical approaches. Post-op rehabilitation always depends on your fixation. Thank you very much. And we invite you all for the Vatsal Multi-Speciality Hospital are always doing annual program. This is our 12th annual program, Meet the Master. I welcome all the delegates and the faculty organizers of the platform to Holy City Varanasi. Thank you very much.
Thank you, sir. I want to invite Dr. Sumit Agrawal for his lecture on calcaneum fractures.
Good afternoon, respected faculty members and the chairperson sitting on the right. I am extremely honorable so that you have given me a chance to speak at this prestigious PlatesCon. I will be presenting on calcaneum fracture surgeon's perspective. As per the history goes, Dr. Cotton in 1916 wrote that the man who breaks his heel bone is done. He won't be able to return to his work. But after that, in 1820s, 1843, and 1921, with the further improvement and understanding of the anatomy of the calcaneum, we have gone in a different direction altogether. So the calcaneum fracture forms 2% of all the body fractures and 60% of the tarsal injuries. It forms about 75% of them are intra-articular fractures and 25% are extra-articular. Foot position, direction, the magnitude of the force and the bone quality decides what type of fracture the patient will have. As per the anatomy goes, we need to, before we go and intervene, we need to have a 3D anatomy in our mind, and important is the posterior talar facet, which has to be reconstructed as before. Essex Lopresti classification was given in 1952, which described two types as per the direction of force, joint depression type or tongue type. In case the direction of the force is going posteriorly, we will encounter a posterior joint depression type of a fracture, and in case it's an axial load, our fracture line will exit posteriorly and will lead to form of your tongue type of fracture. Sanders classification is a CT-based classification, which is in coronal oblique plane. Type 1 is totally undisplaced. Type 2, 3, and 4 have a different varieties based on the fracture line, which is exiting and starting from anterolateral aspect and exiting at posteromedial aspect. Bowler angle was described by Bowler in 1931, and it is the line forming from superior tuberosity to the highest point of posterior facet, and from anterior process to the highest point of posterior facet. Normal is 25 to 40 degrees, and mainly we are working to restore this Bowler angle. Another critical angle of Gissane is also there, and which you are already aware of. Broden's view, this view's importance is when we are operating and interop in the C-arm images, we need to see whether we are penetrating a subtalar joint and calcaneal cuboid joint or not. Calcaneal axial view shows us the lateral wall blowout, whether the heel is going into varus or valgus, and subfibular impingement is there or not. The big question arises whether we should go ahead operate calcaneal fracture or leave it as such. So the meta-analysis was done and it was published in Clinical Orthopedic Related Research in 2000. John Randall et al. Studied about 1845 articles, and out of that they selected few articles in which it was a random control trial, and they found out that the surgically treated patients are more likely to return to their original work, and non-operated ones will continue with foot pain. operative treatment has to be individualized. All patients should not go ahead with operation, and the patterns, fracture patterns in which the patient is having fibular impingement, significant lateral comminution, and larger volar angle show better outcomes. And what we need to look into is the fracture pattern. What are the associated injuries, associated comorbidities, if there are any, and what is the skin condition of the operating site. The goals of surgery is to achieve a congruent subtalar joint, restoration of volar angle, and we have to reduce the width of the calcaneum and decompress our subfibular space, realign posterior tuberosity, and calcaneum cuboid joint has to be restored back. There are various surgical approaches. Out of those, extensile lateral calcaneal approach, sinus tarsi approach, and minimally invasive approach. Our main workhorse is extended lateral calcaneal approach, in which we have to be worried about your peroneal tendons and sural nerve when we are putting our blade onto the patient. These are the few picks we use intraoperatively. Uh, in case we go ahead and see a joint depression type of a fracture, there are 4 or 5 major fragments. The 4 is the sustentaculum talli fragment, which is a constant fragment, which is attached with the talus with the talocalcaneal ligament. Second is our tuberosity fragment. Third is your joint depression posterior articular facet, and first is your lateral fragment. The first maneuver which we do is we try to reduce fragment 4 with the 2. We put in your sham pin or a thick K wire, try to correct the heel varus, and put 2 K wires to hold the fragment 2 with the 4. And depressed posterior facet is elevated up, and that is the fragment we are holding third and fourth together with another K wire. We should put a screw to hold this fragment together, running from posterior to anterior, from your lateral to medial direction, making sure that we are not impaling our tibial artery or tibial nerve. And the gap which is left behind can be bone grafted, but as per the literature goes, now this bone grafting is not required. We can place back our fragment 1 and put a plate on top of that. And once we finish off our procedure, the suturing is very important. We have to use Algover Donatis sutures only, with the sutures lying over the lateral aspect of our incision. There are various armamentarium available to treat calcaneal fracture. We should see what is right in our hands. There are numerous cases. Mrs. Geeta presented to us with a severe swelling over the calcaneal area. She had a joint depression type of fracture. Our volar angle was just 13.8 degrees. We went ahead. Only thing we have to make sure is there is no touch technique. We should not use our tooth forceps towards our any incision. Only your K wire will be holding back all your soft tissues. The plate is placed in after achieving the adequate reduction as shown in previous maneuvers. The drain is placed back. This is our post-op pick. Initially, our incision gave us a trouble, but later on went on to heal well. This is a Prashant, 23-year-old male. Again, had a joint depression type of fracture. You can see the heel widening. This was the CT, severely comminuted fracture. Again, we went ahead, fixed it with the same maneuvers. Use the K-wire. These are the intra-op picks. We place our plate back. This is our plate post-op picture. Vijay, again 28-year male. Again, he had a joint depression type of fracture. Sorry, I don't have a CT right now, but we went ahead, put a plate in. Jagat, again a patient with a 45-year-old male with a joint depression type of fracture treated by calcaneal plate. The complication, we do encounter complications in spite of our best tissue handling, and these are part and parcel of fixing calcaneal fracture, and regular dressings and post-op care heals these wounds. Poor outcomes are encountered in diabetics, peripheral vascular disease patients, the patient with high BMI, smokers, and alcoholics. In our study, so far we have taken 30 patients into account. 7 we have treated non-operatively, 8 minimally invasive by multiple K wires, and our cannulated cancers through 50 underwent extended lateral approach, and AOAFS score, hindfoot score, what we have used, about we are able to reach about 70 to 80 as out of 100. So take home message is take an expert advice. Not all calcaneal fracture has to be fixed by a plate. In case it's an open fracture or the patient which requires minimally invasion, we should go ahead with minimally invasive approach. Thank you for your comment.
Thank you, Dr. Sumit. Any questions for this lecture or for previous lectures from the audience? So we are done with this session, and there is a slight change in program. We are conducting case-based lectures, which were previously to be held in the last, before the HTO and BHO HIP session. Is that okay, sir? Manishi, sir? So we are conducting last session.
Now I request Dr. S.K. Upadhyay sir to please come to the stage for same session. I will request Dr. Radheshyam, Dr. Rohit Gupta, Dr. M.S. Baghel, and Dr. Suresh Jaiswal also. I request chairpersons please come on stage.
नहीं लक्ष्य चालू HTO भी बता रहे हैं ना क्या करा रहे हैं नहीं करा रहे 2 लोगों को बिना आपको पढ़ाया क्या अभी ना पढ़े आए हम पढ़े भी नहीं बिना पढ़े छोड़ दो जल्दी खत्म करना before the time.
I will request that presenter to make it a crisp and short because we are running short of time. We are already late. So make it compressed to 8 to 10 slides only. Dr. R.K. Singh, Dr. Neeraj Agrawal, Mohammad Yunus, Dr. Pankaj Jaiswal, Dr. Radheshyam, Dr. Rohit Gupta, Dr. M.S. Baghel, and Dr. Suresh. We are merging both the sessions simultaneously.
Dr. Aditya Narula, are you ready for?
Good afternoon, everyone. Thank you for the opportunity to present the case
Okay.
on this dais. I'll be presenting a case of a compound tibia fracture done with before plating. So let me give you a brief history about the patient. He's a 52-year-old gentleman, met with a road traffic accident, presented to me with compound type 2 fracture of tibia condyle with committed diphysial extension. Unfortunately, I don't have the photo of the wound at the time of presentation, but I'll be showing you the X-rays. This is the X-ray at the time of presentation. There is a tibial condyle, lateral condyle fracture, there's split and depression, while a coronal split fracture of the medial condyle and a severely committed diphysial fracture of the tibia shaft. Surgery was delayed for a couple of days due to financial issues, though there was not much of swelling, and he had been given option to go to a government hospital as well, but he wanted to continue for treatment over there for a couple of days. There was no CT scan done due to financial constraint, and surgery was planned with debridement followed by a maple lateral tibia condyle plate and also a medial or a posterior medial tibia plate on the OT table. So I was going to operate this patient and did debridement, mypoportable condyle plate. Then there was a percutaneous screw we had to put for a coronal split of the medial tibial condyle. But then there was sudden change in the plan. The patient had cardiac arrest and we had to stop the case immediately over there. I started with the incision over the medial side, but then I had to stop. This was the first post-op X-ray, which we got after a couple of days once he was stabilized. And this was the bone condition on the day of dressing. So you can notice that on this side, this was the bone at the time of presentation, and there was a bone or anteromedial aspect of the tibia as well, which was sutured after debridement. This was the bone which we were starting to operate, and then he had a rest, so we just had to staple it off and move ahead and revive the patient and shift him to ICU. So after 4 weeks, this was the X-ray, and I have already told the patient that we couldn't complete the surgery, so we might be required to do a second surgery later on at a later date. And after 8 weeks, heart skipped a beat when I saw this X-ray. There was lysis, and I already have given option to the patient that we might need to go ahead with a second surgery or with medial plate and bone grafting or start injection teriparatide. There were a few papers on it of injection teriparatide in which there was a good result in delayed healing of delayed union of bone. But he opted for conservative management because there was previous risk he underwent during the first procedure. Little sign of relief was there after 2 months of initiation of teriparatide, in which there were signs of callus, and after 9 months of time, it finally united. This was the range of motion, and this is a walking video of the patient at 9 months of time. So the take-home message in this case was MIPO preserves osteogenic potential and it's biological friendly. Less surgical trauma and soft tissues can be handled very well. There is less intraoperative bleed. Wound handling is better, and plastic surgery intervention, if required, can be easily done. If neck surgery is required, it will have a better chance of soft tissue coverage. Thank you so much.
Thank you, Dr. Narula. Now the next speaker is Mano Luthra. Please stick with the time. You have 5 minutes only, so stick with time and finish within time.
So, good afternoon. I thank Neeraj Orthopedic Association for giving me a chance to present on this dais. So, I have a presentation on humerus fractures and different ways to treat a simple fracture. We all know this can be done with conventional plating, all humerus shaft fractures, but there is a minimal invasive way also. And just for description, we have divided it into three types: sharp, proximal, extraarticular, and distal fractures. How can we accomplish a minimal invasive plating in proximal fractures, sharp fractures, and distal fractures? So this is a case: proximal extraarticular fracture with a large comminuted medial fragment. A trans-deltoid approach was used, and this was the immediate post-op period. Whenever you do a lateral plating, philos, you have to dissect the radial nerve before sliding the plate so that you can easily visualize that you are not injuring the radial nerve. This is a 3 month post-op. Patient went on to do well. It's a concept. It's not a, we try to achieve relative stability by minimal invasive plating. Another comminuted fragment. This time around, we have used a philos, bent at 90 degrees to form a spiral plate, and the reduction, you can achieve it all the time. There's no problem achieving the reduction. Bending the plate achieves greater stability and the radial nerve is saved. Which are fractures, can be divided into transverse, oblique, comminuted. So in a transverse fracture, this is a preoperative or intraoperative planning. You put the plate on the arm, mark your holes, give incisions. You don't have to isolate the radial nerve in this case. And the reduction almost is always there, you don't have to struggle for it. This is union at 3 months. Another example, oblique fracture. You can use 2 screws, 3 screws, depending on the quality of the bone. 6 weeks, 4 months. In a comminuted fracture, the life is simpler if you do a minimal invasive biological plating. You don't have to worry about the comminuted fragments. Leave them where they are, and they go on to unite very well. Segmental. Now, we can always nail it, but problems associated with nailing are there, rotator cuff problems and all. You can slide in the plate, leave the middle segment wherever it is, and everything goes on to unite because it's biological plating. Another segmental fracture, look at the reduction, the same as you achieve in open reduction. Distal fractures, if you can get 2 screws distally, believe me, this is a good option. Just slide the plate, catch hold the plate distally, put 2 screws, and you're done. The plate automatically gives you reduction, a straight bone, a straight plate. If you put a straight plate on a straight bone, you are definitely going to get a reduction. The patient is placed supine with the arm resting on radiolucent table, elbow flexed to 60, forearm supination, confirm fracture rotation, choose the longest plate, make proximal distal windows, insert MIPO elevator, make a drill hole before sliding the plate in the center of the bone. Slide the plate, put in a screw that is loose, don't tighten it, catch it distally, achieve your reduction, ask your assistant to hold it, and you're done. So around 80 cases we have done, 1 non-union, 2 neuropraxias. We had neuropraxias initially, so we thought what was the reason behind it. Now we don't put retractors on the lateral side in the distal window. We just retract it with a 90-degree retractor, and the radial nerve is automatically saved.
You have it, just 1 minute to complete your.
It's over, sir. What precautions? Elbow has a tendency to go into flexion, so encouraging active extension initially helps preventing that. The radial nerve is always preserved, that's not an issue. It's a daycare surgery, so the patient goes home same evening. Thank you very much.
Thank you, Dr. Krishna. Next speaker is Dr. Dharmen. Topic is Stabilized Plate, Innovation and Development. Dr. Dharmen.
Good afternoon, everyone. I'm going to present SWM plate innovation and development. So recon plate are used for the SWM fracture fixation. It can be locking, non-locking. On the basis of contouring, it can be nautical, non-nautical. On the basis of material is titanium or SS plate. On the basis of shape, it can be C shape, J shape, straight plate, or it can be divided also on the basis of the reason. Superficial, SI joint plate, interior column plate, and posterior column plate, and quadrilateral plate. On the basis of function, it can be divided into spring plate, neutralization plate, and reduction plate. And patient specific plate is also available, and other specialized plate is available to treat the specific fracture. These are simple recon plate used for stubborn fixation. Coming on the region specific plate, this is superficial plate. It has a broad area in between, or it has a two hole in between, which is for rectus attachment. And generally 3 or 4 screw on other side required for to fix the pubic symphysis diastasis. This is a side joint plating. Generally 2 plates are used for treat side joint disruption. One plate is along the pelvic rim and other is perpendicular to the first one. And coming on to this transiliac joint, this is for sacral fracture, and generally 2 or 3 screw on other side is required, but it has a one problem. So this sacral fracture are nowadays treated with spinopelvic fracture, spinopelvic fixation. And this is simple posterior column plate. Treat the posterior column fracture. Generally, we can utilize whole of the ischial tuberosity if the fracture is below the lower side of the posterior column. If there is a posterior column and posterior wall fracture, then first we need to reduce the posterior column and support it with the plate, then to reduce the posterior wall against the posterior column, and then fix the posterior wall with the recon plate. If there is a small fragment of the posterior wall, marginal fracture of the posterior wall, then it can be fixed with spring plate. Then we can put the neutralization plate. This is simple anterior column plate, C type or J type. J type plate used when there is high anterior column fracture. This is spring plate used when there is a marginal fracture of the posterior wall for the better purchase and fixation of the marginal type of the posterior wall. Or it can be used as a spring plate for the quadrilateral plate fracture and eccentric hole is present to compress the quadrilateral plate fracture. Coming on to the specialized plate, this is suprapectineal plate. It has a suprapectineal plate along with inferior extension, which is for the quadrilateral plate fracture fixation. This is infrapectineal plate. It is used when there is a quadrilateral plate fracture associated with attached with the posterior column. So with this plate, we can reduce and fix the quadrilateral plate fracture. And if the posterior column of the fracture is attached with the quadrilateral surface, then this type of a plate can be used to fix this fracture. These are safest zone. This green area is the safest zone to fix this kind of fracture, which is associated with quadrilateral plate involvement. This is oblique ilioischial plate. We are now using this kind of fixation through the Stoppa's approach. The posterior column fracture fixed through the Stoppa approach through this ilioischial type of the plate. These are specialized plates for the quadrilateral plate. This is beam plate. This is calcaneum. Clocking calcaneum plate can be used for the quadrilateral plate fracture fixation. This is omega plate used for the fracture for the quadrilateral plate fracture. This is a specialized plate of the Professor Sensor. It is used and when there is a combination and combination and impaction of the stubborn, I provide a better stability and preventing impaction, means control the collapse, later on collapse. Nowadays, 3D printing model used to pre-operative reconstruct the plate for the specific fractures. So coming on to some important cases, we covered the almost all the type of the plate. This
Dr.
is-
Dharmen, you have only 1 minute to finish the speech.
Okay, sir. So this is my first case. This is a fracture posterior column managed with the KL approach. This is having good clinical radial outcome. This is a J-type place used for the anterior column, and this is the T-type fracture used for stopper approach, internal plating done in this case. And this is both column fracture managed with this modified stoppers approach with internal plating of the posterior column. Again, this is both column fracture managed with the stoppers approach, internal plating of the posterior column. This is the here the intrapectinal plate and suprapectinal plate used for the both column fracture fixation. We here the anterior column with quadrilateral plate fracture managed with the internal plating of the posterior column along with the spring plate and anterior column fixation will be in the C type of plate. This is the impaction injury of the anterior-medial bone impaction of the sternum managed with supra and intrapectinal plate fixation. This is isolated quadrilateral plate fixed with the two vertical plate fixed into anterior and posterior column. This is simple pubic diastasis fixed with symphysial plate. This is combined pelvic-tubular injury managed with the side joint fixation along with the stopper approach managed with transverse fracture and pubic diastasis. This is last case. This is a combined pelvic-tubular fracture with hip dislocation managed with the hip reduction preoperatively and then posterior wing as well as the transverse fracture with posterior wall managed with same set in first setting, later on with the stopper approach managed with anterior wing injuries. This is post-op X-ray. We are welcoming to next IOCON 2022-3. Thank you very much.
Thank you, Dr. Dharmen. Thank you. Now the next speaker is Hemant Krishna Maurya. Is he here? Yes, please come on, dais. Now, Dr. Maurya, you have to deliver lecture on MIPO technique, fracture shaft humerus. Please come fast, and you have to complete within 5 minutes. You have only 5 minutes. Bus. Bus last time.
चल रहे हैं 12 13 1 2 3
Presenting case of 24-year-old female, presented with pain and swelling lower third of her left arm, and when she comes to me, already 3 days back, so swelling was subsided. After taking radiological examination, there was fracture lower third of humerus with butterfly fragment medially, and she was very much worried about her fracture fixation without any surgical scar. So she was requesting for insisting also, sir, साहब मेरा ऑपरेशन बिना कैसे भी कर दीजिए, प्लास्टर सही कर दीजिए. So we planned for MIPO technique, fixation of lower third humerus. In order to gain length of the humerus, I have inserted TENS nail through medial approach. A tiny incision was taken in medial aspect of the lower humerus, and then tunnel made through Steinman pin, and then TENS wire is passed. And reduction is achieved, and fixation was secured. And in order to maintain the fixation, I put plate, a long plate, extra-articular, and two separate incisions were taken. Initially, lower third, in a curvilinear incision for lower end, and superior incision just above the fracture. And after dissection, soft dissection, we find the radial nerve, and which is retracted medially, and then finger to finger dissection done. And with the help of periosteum elevator, we just after soft tissue stitching, we place plate through lower end, and then plate is passed over there. And after that, this is final picture after fixation. This is post-op. Please play view. This is immediate post-op video. This is after one and a half months.
Okay, that's good. Carry on. Go forward.
Thank you.
Have you completed your?
Yeah, yeah.
Okay, okay. Thank you, thank you. नहीं end हो गया. Okay, thank you. Next session कर देंगे आप? Okay. So next session will start. So I'd like to welcome Dr. Ajit Sehgal. So you are ready with your presentation? Yes.
Thank you, Dr. K.D. Tripathi and Dr. Manishi Bansal and the whole organizing team for inviting me here to talk on my topic of tip and tricks on STO. Our Prime Minister has given this slogan, Atmanirbhar Bharat. So, I am giving you Atmanirbhar Indian implant, Dr. Sehgal STO plate. Be Indian and buy Indian. How I do the medial wedge open osteotomy with Dr. Sehgal STO plate. This is the patent of this plate and the trademark. As you all know, there are the different surgical treatment of the osteoarthritis of the knee. The main indication is the persistent pain even on rest and disturbing the sleep.
and patient is not responding to the conservative treatment. Other important point to be considered that patient has good vascular status, good muscle strength, and good motivation to carry out their rehabilitation program. And the other factors, they include the age of the patient, the degree of deformity, condition of bone, weight of the patient, and red flags, especially you must see diabetes and hypertension. These are the different options you all know: arthroscopy, high tibial osteotomy, medial wedge open or medial or wedge close osteotomy. There is another type of osteotomy, dome osteotomy, and unicompartmental knee replacement and the total knee replacement. These are all surgical options you all know. High tibial osteotomy is indicated in mostly below 60 years of age, especially in those patients who want to lean forward. Varus deformity less than 15 degree and fixed varus and fixed 15 degree flexion deformity. They are suitable candidate for the high tibial osteotomy. This already I have told that STO is contraindicated if flexion is less than 90 degree. Tibial subluxation, lateral tibial subluxation than 1 centimeter is a contraindication. If instability in full extension is present, then it will be difficult to get full correction by STO. Planning. How much is the deformity? Where is the deformity? How much to correct and where to correct? This is the first step to take a scanogram of the both lower limb. These are the different physiological angles. These are the causes of varus, maybe joint erosion, metaphyseal varus, and the lateral ligament laxity. You must identify the metaphyseal varus. This is the most important point for the STO is the Fujisawa point. Fujisawa point is that at the proximal tibial plateau, the Fujisawa point is at the 62% of the proximal tibia. So when you get this scanogram, they will give you the idea of deviation, so that you must get that wedge open or close to get the Fujisawa point for the full correction. This is the tibial slope, the angle between the line perpendicular to the tibial axis and the posterior inclination of the tibial plateau. The site of osteotomy. Osteotomy is generally performed less than at least 3 to 5 centimeter distant to the joint line, and done I do just above the tibial tubercle, which exerts compressive effect at osteotomy site, and it heals faster. The specification of this plate is a locking compression plate used to correct the genu-varus deformity of the knee joint in advanced third degree of the osteoarthritis of the knee. The upper portion is a T-shaped and had a bend. It has got a 3 parallel screw, and below this is a hole for 45 degree screw. This plate works as a column, and these 3 parallel screws, they help in weight bearing, and this bend also supports the proximal part of the tibia after the osteotomy. And the 4th hole is for the 45 degree screw. You cannot put a weight in a column if there is no beam. So this 45 degree angle screw works as a beam, and the rest of the another hole is for the block to hold the osteotomy, and lower 3 they are the hole for the screws. This is the middle portion, as I already described you. I have got 4 blocks which are connected to the plate to maintain the osteotomy site. It has got 4 millimeter, 8 millimeter, 10 millimeter, 12 millimeter, and 16 millimeter. This is the lower portion of the bone. So what are the advantages with this plate? With this plate, instrument inventory is very less. It gives a full correction of the genu-varus deformity, and surgeon can check clinically, radiologically, and with aligner that deformity is fully corrected. The plate will be same, universal plate. For all the patient, only the blocks will be needed as per degree of correction of deformity. This is very low priced implant, and it can be used by common people. No bone grafting is required. Operation is easy with this plate, and block and can be performed even at a smaller center. It is our own Indian product. This is the comparison with other plates. This is comparison with other plate, Tomofix, Kudu plate, Tomofix. So coming to the preoperative evaluation, careful preoperative planning is essential for the success of the operation. A satisfactory range of the movement and joint space congruence will allow transmission of the weight bearing following realignment. Bone density and ligamentous establishes should be sufficient for the function of postoperatively. All blood parameters and cardiac assessment should be done. After retraction of a part of PES, giving an incision over the PES for 5 centimeters at the medial side of the upper tibia. A parallel K wire are passed, two parallel K wire are passed at 45-degree angle from medial to lateral side pointing towards the fibula head. This you can see that there is two K wires are passed, one at the upper portion of the tibia, another at the inferior portion of the tibia. The osteotomy is done with saw in 50 to 60-degree flexed knee and Homan retractor placed under the surface of tibia to prevent neurovascular damage. If needed, the posterior cortex can be divided by the osteotome or corticotomy knife, corticotomy osteotome, which is used for the irregular procedures. Open the osteotomy and check the block of the different side. Check full correction of the deformity clinically, radiologically by CM and with aligner, and then maintain the gap with the spatter. Take out the block, attach with the plate with locking screw at the bend. There are two holes depending upon the level of osteotomy plate. Place block and bend the plate will support the condyle of the tibia, helps in weight bearing. Slide the locking plate and block in any of two holes, block of the osteotomy side to maintain the osteotomy gap. Fill the hole with locking screw above and below the osteotomy size. Close wound, there is no need of plaster. Physiotherapy is started from next day and patient weight bearing can be started in 2 weeks after the removal of stitches. This is the bone model demonstration. You can see it's just initially you put the plate over the skin so you can know the upper limit of the plate, and there are two K wires you can see here. You can see that there is an upper limit of the plate and you put two K wire, one at the upper limit and another at the middle of the middle hole so that you can know the osteotomy site. Give an incision. Incision is given. On the medial surface of the tibia. Then place the K wire, insert the K wire, initially pointing at 45 degree towards the tip of the head of the fibula. And you can see that this wire goes at the angle of 45 degree. After putting one K wire, you put another K wire, and after putting the K wire, then start the osteotomy below the K wire, because if you are doing osteotomy above the K wire, your hand may slip and you can go into the intra-articular portion, or the upper portion may be very short. So just start the osteotomy below the K wire. You can see that osteotomy is started below the K wire. And when you have reached up to the level of just at the up to level of the tibial tuberosity and a little more, then stop doing the this mechanical osteotomy and complete the osteotomy with osteotome. You must take precaution during doing this osteotomy. Number one, you should flex the knee up to 60 degree, place mob and then retractor, so that all the vascular structures, they are under the retractor, and then complete the osteotomy. In this completing the osteotomy, you must know that you should move forward. Don't move this osteotome up and down. If you are moving osteotome up and down, you can create an intra-articular fracture. So always go towards the 45 degree and below the KY. And complete the osteotomy with osteotome. After completing the osteotomy, just place the block so that you can know that with this block the deformity is fully corrected, and then attach that block to the plate, and now you can insert that plate with the block. You just attach this plate to the block and insert that plate into the incision and put that block like this, put that block into the osteotomy. And after putting the block into the osteotomy, if plate is away from the bone at the lower portion, just clamp the plate and put a cortical screw. Then plate will be attached to the bone. Fill all the other locking screw, and in the last, take out that cortical screw and replace it with the locking screw, so that plate is fixed to the bone and that block is inside the osteotomy, and that will maintain the osteotomy and will help in weight bearing. Now you can see that plate is fixed on the bone model and the block is maintaining the osteotomy side.
So, sir, time, restricted time, sir.
No, I have given 20 minutes, sir. I have given 20 minutes. Yes. So now you can see that the fixation is complete. You can see that this is a patient. And you can see that after the completion of the osteotomy, joint space is maintained, deformity is corrected. After the 4 months, you can see patient is walking without support. This patient came to me, then 3-4% were holding her, but now she is able to move without any support. See the movement after 3 months. Complete full knee bending, full knee bending. And patient can sit cross-legged. This is result of 3 months. These are all another patients. This is all another patient. This is another patient. You can see the deformity. Another patient. This is when you hold the plate with the clamp. See the clinical result. Another patient. You can see this patient full. This patient is 70 years old, having full knee bending and cross-leg sitting. This is another patient. There are so many patients. Okay, Dr. Upadhyay, I will just obey you. These are the different pictures from the different doctors from AIMS, Raipur, Dr. B.B. Srivastava from Varanasi, and complication if the implant is removed earlier, then correction of the...
No, sir, carry on, go on.
Delayed union is seen in smokers and in diabetics, and infection is another complication. Take home message, Dr. Sehgal osteoplate is a simple, stable device to use. Surgery can be performed even at the smaller center. There is no need of bone graft. Instrument inventory is very small, and surgeon can check deformity correction clinically, radiologically on the OT table itself. And early bed bearing is allowed. And in future, after 10, 15 years, if TKR is needed, then the mechanical access of the joint will be same as needed for TKR. So you can perform TKR after 15 to 20 years if needed. And the most important is implant is cost effective. These are I have done workshop in National Conference, Central Zone Conference in Dhanbad, Bihar Orthopedic Conference, GolfCon, Uttarakhand Haldwani, Siliguri. I have given my demonstration to the Union Health Minister, Dr. Mandavia, and workshop. I have conducted workshop in all the place, in every state almost. And this is the press release by Univarta. This is Varanasi. This photograph is taken by me. And I invite you all on the 19th for the scientific program at Varanasi. And scientific program may be a bahana, but you can come for the Baba Vishwanath. Har Har Mahadev. Thank you.
Thank you, sir. There is a question in the mind of so many persons, where it is available and what is the cost. If you explain, then it will be okay.
Yes, doctor, thank you. This is available with Nebula Surgical, and the cost of steel implant is approximately 7,000 around, and the cost of titanium implant is approximately 14,000-15,000. That includes the whole construct.
Another question that we like to ask is, sir, whether it is necessary to put bone graft in the void.
No,
as a substitute.
There is no need of using I never use the bone graft, and it heals. It starts healing from the lateral side, lateral to medial.
Any questions from the house?
How it is different from any other
Actually, because of the time constraint, I have not given here the detailed comparison between all other plates. I will give you that I've got a different advantages with this plate in comparison with other plates.
वापस आ जाओ.
So thank you, Dr. Ajit Sehgal, for a very nice talk. Now we'd like to invite Dr. A.K. Rai sir for his demonstration on BHU hip and periprosthetic fracture.
I will not let you get home. क्योंकि आप जगह नहीं जा रहा, जगह कैसे रहा हूँ कि अगर मैं आपसे एक सवाल पूछूं, जितने लोग बैठे हैं यहाँ, क्योंकि मैं बेसिक बात करने जा रहा हूँ जिसका बेनिफिट आपको मिलेगा लाइफ और आपके मरीजों को भी मिलेगा। अब मैं एक बेसिक सवाल अगर पूछूं कि आप हेवी आर्थोप्लास्टिक करते हैं, हर व्यक्ति करता है, करते आ रहे हैं। जब आप हेड निकालते हैं एक्टिव एल्डरली पेशेंट्स में और हेड को निकाल के आप गैजेट पर मेजर करते हैं और मेजरमेंट में आपने पाया कि आपका हेड 45 के राउंड से पास हो जा रहा है और 43 से नहीं जा रहा है, आप कौन सा इस्तेमाल करेंगे डॉक्टर साहब? कौन सा आप यूज करेंगे? 43. That is absolutely wrong, sir. It has been proved by study, by calculations, by literature. Europe में nobody does that. They have got all the numbers. मेरा दूसरा सवाल मित्रों, अगर आपके बाइपोलर में एक में 28 का हेड है अंदर में और एक में 22.25 का हेड है, जो चार्ले का ओरिजिनल कॉन्सेप्ट था, लो फ्रिक्शन आर्थोप्लास्टी। अब आप मुझे बता दें, आपका बाइपोलर 52 का जो भी आप लगाने जा रहे हैं, एक में 28 का हेड है और एक में 22 का हेड है, कौन सिस्टम लंबा चलेगा, 22 वाला या 28 वाला? 22 वाला। It will last 10 years more. Third point, because my talk was on the, पर पीड़ा है मुझे, ताकि मैं चाह रहा हूं कि मैं कन्वे कर पाऊं अपना मैसेज, क्योंकि हमारा माइंड जो है ना, जो चला आ रहा है उसी को दोहराता जाता है। जब मैं यूरोप से आया, प्रोफेसर गोयल वाज द हेड एट दैट टाइम, और 45-55 में ऑस्टिमूर लग के आता था, तो मैं पूछता था कि सर एक्टिव एल्डरली लोग गाँव में हैं, इनको बाइपोलर क्यों नहीं लगता? तो उनका जवाब आया कि यार ये 3-4 साल में खराब हो जाता है। ये था सवाल, और दैट वाज द इंसाइटिंग पॉइंट, जहां से फिर हम लोगों ने देखना शुरू किया कि क्यों खराब होता है। तो लिटरेचर में तमाम स्टडीज के बाद ये पता चला कि नेक और कप की हीटिंग जो पॉली से हो रही है, इट इज नंबर 1 फैक्टर। उससे पॉलीथ्रीन डेब्रिस गिरता है और वो शेडिंग करके फाइब्रोब्लास्टिक रिएक्शन करता है और मूवमेंट जाम हो जाता है। आप सबने रिवाइज किए होंगे बाइपोलर, अगर तो आपने देखा होगा कि कितना ग्रेनिश फाइब्रस टिश्यू वहां पड़ा होता है। आज 20 साल हो गए टोटल नाउ फॉर द फॉलो अप, टच वुड इफ यू कैन गो फर्दर, पेटेंट भी मिला। मेरे को प्राइस चांसलर ने कहा राइज बाइपोलर कर दूं, हमने कहा इंस्टीट्यूशन में मैंने काम किया सर, लेट इट बी बीएचयू डिवाइस। नाउ आई स्टार्ट द टॉक फ्रॉम देयर। तो आपने आंसर दे दिया कि आप 43 डालेंगे, नहीं सर, 43 जब डालेंगे तो ये हार्टलियन कॉन्टैक्ट स्ट्रेस दिख करता है। आपने ऑपरेट कर दिया, मरीज आपका गया, आप भी खुश, वो भी खुश। ये 6 साल में फेल होने जा रहा है, और फेल होने के बाद ये आपके पास नहीं आएगा, इट विल गो समवेयर एल्स एंड देन यू विल डू ए टीएचआर और व्हाटएवर। तो यू मस्ट यूज द सेम नंबर। और आपको दूसरी बात बता दूं कि अगर आप एक नंबर छोटा डालते हैं, that does not work as a bipolar. It works like a unipolar. We have done the video and we have proved it, and scientifically also it is correct. You should put the same number. अगर 45 से जा रहा है, 43 से नहीं जा रहा है, तो your number is 44. It should be snug fit. हम लोगों ने भयानक कैलकुलेशन आईटी में हुआ, हर्ट्ज एनालिसिस बेस्ड ऑन द यंग्स मॉडुलस, 200 न्यूटन रेट, मेटल की इलास्टिसिटी, बोन की मॉडुलस ऑफ इलास्टिसिटी। तो ये पाया गया कि whenever you put a prosthesis into the scapulum, it creates a stress. It is about 60 megapascal stress. If you put a larger one, it creates about 25 megapascal stress. If it is a 43 like, but if you put the same number, even number 44 or whatever number comes, it gives you 1.2 megapascal stress. And the bipolar will function as a bipolar. The outer cup will move in the extremes of movement, not before that. So the bipolar which you are using with the even numbers, loose one is a crap, and that is why it fails. And there are various other reasons also of its failure. Neck and cup impingement. Now I'm going to show you the slides.
क्या चीज? लाइनिंग आ रही थी ना, वही ठीक कर रहे थे।
ये बहुत छोटा है, वेरी वेरी मोट, ये बहुत छोटी बात है। वर्क लाइफ में पूरा 3 इयर्स इसको अंदर पीछे ले जाना। ये जैसे कैन वी स्टॉप द स्लाइड हियर, इट मूविंग बाय इटसेल्फ, जस्ट गो देयर। इसकी रोकना है, इसके पहले ही बच्चा छोड़ दो, मतलब फास्ट हो जा रहा है, व्हाई इट इज गोइंग विदाउट। So sir, we know that. We know this fact that it works like a unipolar in 2 to 3 years time. High dislocation rates equal to less than the because of the designs and all. Next one. Yes, right. Polyethylene debris shedding due to neck cup impingement is a very important cause of the failure of the prosthesis. Thin layer of polyethylene causes early revision surgery. A 28 head will last not more than 6 or 7 years. Sacrifice of calcar leads to sinkage of the processes. That is what the Talwaka type processes do. Next. ये स्टार्टिंग की गई हम लोग के, मैंने कहा भाई बीएलक्यू डिवाइस क्या वाला है, ये कब में चेंजेस किए गए अभी मैं आपको दिखाऊंगा। तो इसके बाद हम लोगों ने 6 पेपर भी पब्लिश किए हैं, आई विल शो यू ऑल दैट। ये देखिए, दिस इज अ वेरी इंपॉर्टेंट स्लाइड। ये है कारण फेलियर होने के बाइपोलर का, और ये लिटरेचर में मेंशन्ड है। बट ऑल द प्रोसेसेस व्हिच आर बीइंग मैन्युफैक्चर्ड इन दिस कंट्री, दे कॉपी। हमारा कॉपी करना हमारा आदत है। यूरोप का भी प्रोसेसेस जो है वो भी अभी प्लास्टिक ला रहे हैं मार्जिन तक। इन एवरी मूवमेंट द ब्लडी नेक इज हिटिंग द पॉली and that is creating a reaction. And that's why, because the foreign bipolars are costly and their poly is 10 times less wear, that's why it is surviving and standing the test of time. However, the neck cup impingement problem is there as well, and they have realized that. Bioprocesses were taken in leads, they kept it there for 2 years, and then I was told that Dr. Raj, when we will launch a cheap bipolar in India, we will take it. Look at it, they must have caught. And the vice chancellor had told me not to do that. Don't give them, but it happened. तो ये स्लाइड को आप रखें दिमाग में, और इसको देखिए कि हम लोगों ने इन प्रॉब्लम्स को कैसे किया था। हम ये कैसे चेंज करोगे पॉइंट कैसे चलेंगे अच्छा। तो अब आप देखिए यहां पर जब नेक को पतला कर दिया गया और हेड 22.24, और देखिए कि पॉली मार्जिन पे नहीं आ रही है। Now you look at every other processes that you are using, the polyethylene is very coming right up to the neck, and it strangulates the movement of your processes. It strangulates, and every moment it is hitting the process, shattering of the polyethylene debris. And when I quoted this slide in one of my papers and presentation, I got an email from this guy that you should have taken permission from me, because this is a weird debris from bipolar, femoral, neck cup impingement developed for the past in 1994. So in our design and in this design, we have changed this and got it patented. You see that the poly is traveling like that here. The head is 22.24, like Charlie, neck is like a hanging rope, and there are several other changes. And now the cup has got all the sizes to avoid the Hydrogen contact stress. So please don't use a loose one in your life. Even it is not done from Austin Moore in Europe, but they have got so many things, other things. So if you are moving to loose one that leads to Hydrogen contact stress and wear poly, every moment you walk, 3 times load goes on the hip, and it is giving a thudding. If it is a slack fit, that Hydrogen contact stress is finished. Hydrogen contact stress is a mechanical principle where you calculate how much stress in every load is going on. Next. Now, now this is the, see that I'm not going to explain. This is that formula that is showing you the stress calculation. It's a hard analysis. If your process is load, it gives stress all the time. And it never ever works like a bipolar. That is why the movement ceases within no time. We have published papers of 15 years duration where there is a 15% movement is preserved between the head and the plastic here. And the outer cup moves. There is a video, I have not brought that one because my topic was different. I'm going back to that. In the extremes of movement, this outer cup starts moving into the acid developed not before that. And most of the movement initially happens here. Their movement sees a good time, but still at 15 years, there is about 15% preservation of movement, which we calculated by recurrent various radiological method. So, that's not the now statement true that the bipolar becomes unipolar. So, bipolar becomes unipolar because of the Hydrogen contact phase. You are using a loose processes, you are not putting the exact size, and second, the neck hitting the plastic that I showed you. I'm showing you the processes also. Now, sorry, this is the book that is coming with all the calculations in the Amazon. I'm sure once it comes in many of the conferences, I'll keep it there. This is not for the self-propagation, but this is for the scientific knowledge that now we have to change. Austin Moore gone, nobody uses that. Indication 80 plus, life bound 2 years. Now take bipolar. Bipolar, the crack they're using, change from that. Now coming total hit. Now I'm going to talk and show you to show that paper. Total hit. ये पेपर है अमेरिका से, अभी रिसेंटली पब्लिश हुआ। ये डॉक्टर भंडारी पेपर ये। That's right. This paper it came in 221 का है तो है 219 का। This guy is consultant in USA, Canadian Research Institute, 10 countries में ये स्टडी हुई। एक एक्टिव एल्डरली 60-65 में जब पूरा डूबता है तो टोटल हिट करना चाहिए कि बाइपोलर है भी आपके पास। And this paper conclusively proved that there is no significant difference in THR and a heliarthroplasty bipolar. Which bipolar that you decide. You want to use the DAB or you want to go some revised version or something advanced. So that is very clear. So you don't, now the marketing forces and the big doctors and consultants, they also advise you to do a THR. Why? You take the money, do a simple processes and that will last 20 years plus and take the money, the monetary part. Why you do a THR? Why? Because it is a long time, there is more bleeding, it is not economical, infection rate, dislocations, you don't allow your patient to sit and squat after that. Why don't you use a process in the cement and allow your patient to sit and squat and run whatever it is you can do? So that is the thought process we have to change. I'm not going to say that you do this processes, but then if it is good, also saying if something is good, it is good. You have to take it. Next. और ये हम लोगों ने और भी स्टडी किया बैकग्राउंड ये एक था पेपर वाला दो है ठीक है हमको पुराना right. And you get that as a year, and you get a journal of clinical orthopedics and trauma, and you get a beautiful gate. Why? Because we studied the offset on the normal side and offset on the side where we have put the processes. And there was this processes. I'm going to say the BHU hip device or BHU bipolar processes. जिसकी मैं बात कर रहा हूँ. Offset were no significant difference. So the gate was good. So that paper we have nationally IGO में publish हुआ as original research article. Now the time has come that right. See, that's how we measure the offset. And this offset from there to there and there to there has, in a study around 50 patients, the offset was no significant difference. Next. नहीं मतलब नेक्स्ट से आप सुपर ओरिजिनल जाना चाहता हूँ यहाँ पर सारी स्लाइड्स हाँ ठीक है ना ये रहा ये हो गया ये तीनों आप ये हो गया राइट ये 10 साल का फॉलोअप है that was original research article published हुआ ये यहाँ पर हम लोगों ने we used it in the roughest development. I'm not going to advise that. My only indication is the intracapsular fracture in femur in active elderly. Now, what approach? Any approach that you are familiar with. And I will just like to show you that. Go ahead.
Sir, please restrict with time, sir.
Okay,
Only.
time, that's fine. I'm concluding it now. So, the point is, है सर, in a heavy patient, it sinks in 7 years time. Now, and in a sternum, change vertical. In a sternum, when you put it, lights on, it goes into the sternum. In extremes of movement, it can dislocate. This is a ellipsoidal neck designed not to dislocate. The calcar angle was changed. Why? Because you can get a hard calcar bone where it sits. The neck cross movement is much more than this, which traps and
Light on the
fills the
TV.
copy of color. So this was the master.
Yeah.
And the second thing,
ऑर्गेनाइजर्स क्या लाइट जल सकती है क्या? थोड़ा सा सब लोगों को दिखाई दे. हाँ, यस यस यस.
just a minute, sir, let me tell about the version. When you put these processes and its posterior column is matching with the lesser trochanter anterior border, forget about version. You are very good. You can allow your patient to sit on a squat on the third day. This posterior collar, in a case you are confused about version. Normally you do posterior mover every day, bipolar, whatever. But if you confuse this posterior collar, if it is collinear with the anterior border, collinear with the anterior border of the lesser trochanter, you will be fine. आप posterior approach कर रहे हैं या lateral कर रहे हैं, कुछ भी कर रहे हो, मैं तो lateral कर रहा हूँ. So these are the things I want to clear. Thank you very much for patiently. I hope.
Thank you.
I was worried whether I can convey my message or not. If somebody wants to ask questions, please. I want questions. Yes.
All sizes of your prosthesis have the same stem diameter.
Yes, sir. Second question. Yeah, same. We have got all the numbers. Okay, use the cement, sir. Uncemented and cemented, two varieties are there, and they will fit in.
So you are using cemented or?
I am using cemented mostly.
तो तुम आगे जाओ.
Second question. My doctor colleagues
आगे
asked,
जाओ.
is it having modularity? No, you can't choose the modularity. Modularity is increase the price. For those who might be no. I told you, if you put a little finger here and cut the calcar, 99.99, both the limbs are equal, sir. So why do you need modularity in a neck fiber fracture in an active elderly patient? Well, we can ask sir, to ask the guy to make a modularity. लेकिन modularity करने में कहीं option तो बिगाड़ दे मेरा वो. अभी जो option है, वो fantastic है. We have proved it. अब आगे. When I deliver lecture in Philippines, they call me, ever your neck broke, sir, center में. 10 millimeter diameter है वहाँ neck का, metal का. None of them broke. अफ्रीकन का सर्जन कहता है कि आप आके यहाँ पर करिए, यहाँ प्रमोट करिए. हम वेट कर रहे हैं शायद मेरे मरने के बाद, क्योंकि ये डिजाइन है, कॉपी तो हो जाएगी, कॉपी तो कर ही लेंगे लोग करने वाले. ये जो कॉपियर तो बैठे हुए हैं, जितने बाइपोलर हैं यहाँ, सब तलवार की कॉपी है. And that is it. You have proved it.
Thank you, sir. Thank you. Thank you, sir. Please get your certificate.
For the patient.
Thank you.
यहाँ खड़े हैं, अपना बाइपोलर ट्रैक प्रमोट करते रहते हैं, हमारा और लिखा है
वो क्या नाम है उसका?
प्रदुम इधर आओ, इधर आओ, यहाँ पे आओ, देखो आता है, लेके आओ। अच्छा स्टेज पे जाओ, चढ़ जाओगे, जाओ देखो। हाँ जाओ। गोलू भैया को पकड़ा देना, वो गोलू खड़ा है उधर उधर, गोलू भैया वो उधर उधर उधर। अरे कैमरा कैमरा, हेलो ऊपर से ही।
सर आप सेंटर में आइए। हाँ मेरे ऊपर मत बैठना बस।
रिकॉर्डिंग चालू है, प्रदुम ने रिकॉर्डिंग चालू है।
ग्रुप में शेयर हो जाएगा। रुको
रुक जाओ।
एक मिनट रुक जाओ। कैमरे वाले को बुलाओ, सर का सर्टिफिकेट दे। कैमरा मैन इधर आओ।
आगे मत जाइए भैया।
कैमरा मैन
हाँ जी 15 साल।
अब मैं बिल्कुल सकते हैं। हो जाएगा सब।
आप मुझे नंबर दीजिए तो मैं आपको भिजवा दूँ। आप मुझे नंबर दीजिए। नंबर क्या पोस्टल से आता है पोस्टल है।
और अपना आप हमें इसी पे जो हमारा ये व्हाट्सएप ही इस पे आपको पूरा एड्रेस भेज दीजिए, बस लिख दिया ओके से क्योंकि मैं लाइव मेल से भेज दीजिए, कोई बात नहीं।
कई लोग सब नहीं कर रहे।
वैसे जितने बैठे हैं बस वैसे आधे सुनो
मेरे पास है।
ये तो बॉस के पास है।